Good afternoon or good morning, depending on where you are, and welcome to the Indian Health Service COVID-19 Clinical Readiness and Patient Care Teleeducation session for March 18th, 2021. My name is Sean D'Andrea. I'm the Emergency Medicine Chief Clinical Consultant for IHS. Today, we've got a very interesting and timely topic, and we've got a full, the hour that we have available will almost be completely filled by presentation, though we'll try to keep plenty of time, if possible, for a Q&A. We're joined by Dr. Ihs Vahia, who is a faculty at Harvard Medical School, a geriatric psychiatrist, and who serves a clinical role at McLean Hospital in Belmont, Massachusetts. And the discussion today will revolve around older adults and the mental health effects of COVID-19. Please share your Q&A questions in the chat feature of Zoom. We'll do our best to field those questions when Dr. Vahia has time towards the end, or if we have the opportunity to inject some, we will. There will be CME credit available, as always, with the completion of a post-session survey, which will be made available in the chat feature. The link for that will be cut and pasted over there towards the latter part of the session. Today's session is recorded, and your attendance serves as consent to be recorded. That recording will be made available on the Project Echo website following today's session. Please see the email invitation for a copy of Dr. Vahia's slides today. And again, CME is available following completion of the post-session evaluation. And with that, I'm very pleased to turn the floor over to our presenter today, Dr. Ihs Vahia. Thank you, sir, for joining. And you may still be muted if you're trying to speak.
Yeah, can you hear me now? And my slides are visible?
Yeah, slides look great. Can hear you loud and clear.
Perfect. So thank you for Sean. So my name's Ihs Vahia. As you said, I'm a geriatric psychiatrist at McLean Hospital, and it's a great honor really for me to speak to this topic today. I will share just on a personal note that I had the privilege last week of being at the Northern Navajo Medical Center in Shiprock, New Mexico, where it was the first time I've had a chance to work within the IHS system. And it was a deeply enriching experience, one that I think I'm going to allude to during my talk today, because I think I made some observations and just learned some things about how there's variances in the way the pandemic has impacted aging and mental health just based on where one might happen to be located. Just a quick note of my disclosures. I have a number of different research supports, but no financial relationships of any sort that are relevant today. I will add that I receive an honorarium from the American Journal of Geriatric Psychiatry, for which I'm the COVID-19 section editor. And a quick touching on today's learning objectives. I'm going to talk a little bit about the mechanisms by which the SARS-CoV-2 virus impacts the brain, which in some ways is the fundamental basis for why there have been and why we believe there may continue to be mental health impact from the virus. I do want to touch upon the process of grief and how COVID-19 impacts this in older adults. I want to talk a little bit about the impact of loneliness and isolation in this population, but also mechanisms of resilience that we often see among the older population. I understand we're going to have questions at the end, so I'm going to try and leave some time for questions before I'm done. So a lot of what I will be discussing today is new knowledge, and it's about a lot of insights we've gained over the course and the experience of the pandemic. But this has been painfully acquired knowledge. I feel like I would somehow be failing if I talk about this without acknowledging the loss that the pandemic has incurred. And I speak with humility for that reason, that there has been devastation. That's the reason we've had to pay attention to this topic, and it's very much an ongoing story. These are data from the Navajo Reservation, and I like referring to these because these data and the trends are better than just about anywhere else in the country, which I think is a great tribute to the the people at the IHS and at the NNMC in particular. So let's go back to the basics, and let's think about how the SARS-CoV-2 impacts the brain. We know that its primary mechanism of pathogenesis is by binding to the ACE2 receptor. And this receptor is present in a number of different organs. It's why COVID-19 can impact a number of different systems. The airway epithelia, of course, but we've now had reports of renal failures and gastrointestinal symptoms and vascular symptoms. That's because the virus has the ability to infect epithelial cells across more or less the entire body. It has a direct pathogenic impact on neurons, but also astrocytes and oligodendrocytes. So it can have a primary neurotoxic effect. And the ACE2 receptor is specifically concentrated in the substantia nigra, the ventricles, the middle temporal lobe, the posterior cingulate cortex, and of course the olfactory bulb. We know about the loss of sense and smell, but a lot of those other regions have associations with emotion regulation, and with executive functioning. So it stands to reason that there are mood and cognitive effects that come from direct viral infection. These have not been studied quite as closely, partly because it's difficult to study the brain while there's an active infection in place. But I think we will start to see some of the fallout of this over the coming months. It's a good time to sort of start watching the literature for emerging trends around mental health. But not just the damage it does, but the ways in which this virus can enter the brain. Those that are greater authorities on that part than I am have said that they haven't really come across a virus that can enter the brain through so many different mechanisms. It's capable of spreading directly through the synapses. We know that it can track upwards through the olfactory nerve, which is the commonest mechanism of neuro-invasion. But it can also cross the blood-brain barrier directly by infecting leukocytes, and it can travel up the vascular endothelium. So it can enter the brain through the blood-brain barrier, directly through nerves, and through the blood vessels. So there's a potential for great neurodevastation. And I think we're only starting to see how this might all play out. And then finally, because any viral infection can cause an inflammation, there's a potential for direct inflammatory impact on mood and cognition. And we know that inflammatory states can impact both. One of my colleagues at Beth Israel Deaconess, is Sharon Inouye, who might be the world's leading authority on delirium, wrote this feature in Nature in December, and it was an alarming one, only because we know that delirium is common on COVID wards. The bigger question, though, is whether experiencing delirium as a result of COVID may increase the risk for dementia down the line. Right now, COVID delirium rates are as high as 65%. Hundreds of millions of people may have been infected, and we don't even know what the true infection rate might be worldwide. So are we in fact looking at a potential COVID-induced dementia crisis in a decade or so? It has never been clear whether delirium predisposes to dementia. There's the chicken and egg question, whether having delirium somehow causes brain changes that lead to dementia downstream, or in fact, is the pre-existing presence of dementia risk factors likelier to cause delirium in people anyway? We do believe there is an association, but we don't know what direction that association works in. Regardless, that combination of inflammation, disruption of white matter architecture, and damage to the glymphatic system, all of which SARS-CoV-2 can do, are known risk factors for both delirium and dementia. So this is still new science, but we're in the early stages of starting to do long-term monitoring, including at McLean Hospital, where I'm in the process of setting up a long-term COVID outpatient service intended to be a research clinic to answer these very questions. This is now standard of knowledge, but at the time this paper was published in April last year, this was the first reported case series of altered mental status as a presenting symptom of COVID-19 in older adults. This has become a paper of some historical importance. Uh, but this was a case series from Emory University in Atlanta, which presented 4 patients, all of whom had confusion before they tested positive or before they had any respiratory symptoms. There was some variance. One patient had confusion with agitation and refusal of care, kind of the classic agitated delirium. One with confusion, apathy, and incontinence. And then 2 patients with confusion, disorientation, and sort of more physiological symptoms like loss of appetite. So this is, according to some, a virus that, though it's considered a respiratory virus, it's really a pan-systemic virus. And some have gone so far as to say that when all is said and done, we may find that its neuropsychiatric damage may be what's costliest over the very long term once the acute pandemic is controlled. So we'll have to watch and see. But there's far too many unanswered questions at this point. Let's talk about some clinical considerations, though, about the challenges posed by the pandemic in everyday clinical care. Uh, because so much of geriatric psychiatry involves care for dementia. And I would be curious to hear from some of you about what the impact on dementia has been within the IHS. But we found that for people with dementia, there was disruption at multiple levels. For one, people with dementia have challenges just hand washing and maintaining distancing and wearing masks consistently. There have been constraints in available resources for dementia care from the economic fallout of the pandemic. For people that perform clinical care in this population, the inability to do physical examinations, limited neuroimaging, limited neurocognitive testing has meant that for new onset dementia, the workups have been suboptimal. There are risks, of course, with starting new medications when you can't interact with people directly. Also, non-pharmacologic treatments, which involve a lot of closeness and aren't really able to administer them for a while. Now with vaccination picking up, this is starting to come back. Uh, Telemedicine is not always an option. There's worse isolation in community dwelling people with dementia, because in assisted livings and long-term care facilities, even though there was more infection, there was also people around. So in some ways, people that live in the community rather than in facilities were more isolated. And then, at least in places like Boston, an issue during the surge was when there was a need to move beds quickly. What we found is that someone with dementia might be discharged sooner than they would otherwise have been and placed wherever there was a bed available. And that place may not be one that was equipped to deal with dementia. Big one, because these are the first line approaches for dementia care. Said the interaction and touch, plus the possibility that elevated behaviors might be early sign of COVID. Hesitant too, because they weren't sure if they were dealing with an early symptom of COVID. And then the use of PPEs and especially masks, such as from persons that for person share, able to see the face of the clinician can actually be more aggravating. And in fact, it's been easier to just use uh, Zoom or other video conferencing platforms. And then finally, support from families has not been accessible. So disruptions in dementia care all across the system. Nothing to the impact on caregivers. We know at this point that there is burnout among caregivers, dementia, especially during the past year. They have had fewer resources for themselves, including respite care. They've lost their own support. So the things that most of us do, go to the movies or the mall or a restaurant or whatever, all of that's been gone. So the things that help mitigate burnout and fatigue have not been as available. Non-emergent care has not been as, and for any caregivers that own and are. And then finally, grief. believe, and something that my experience on the Navajo reservation sort of reflects, is that as a population, we haven't even begun to unpack what the grieving process should be. And grief does not just mean the loss of people one knew. It also means the loss of life as we knew it. It means the loss of support systems. Um, some losses which may seem minor in context, like the loss of, say, a wedding that was planned or a high school graduation. I think all of these add up. I think that's why at this moment in time, when it seems as though the pandemic may be coming under control, the overwhelming emotion seems to be fatigue, just as much as relief. And I'm going to talk a little bit about that in a bit. Um, the pandemic has also had unique impact on the management of substance use disorders. And some of this has just been changes in the culture, if you will. Alcohol, for example, we've learned that it's important now to establish whether there's been changes in drinking habits during the pandemic. Many of you may be familiar with the term quarantini, which entered the popular lexicon specifically because it felt as though while places were in lockdown, people were drinking more. And that's just social drinking. In the case of tobacco, though, smoking seems to have gone down because we learned that smoking and even vaping may increase the risk of pneumonia or fatal outcomes from COVID-19. In the case of cannabis, use has gone up, but not from smoking or vaping. It's mostly because people seem to have switched to edibles, and especially in places where cannabis has been legalized, which at this point is just about half the country. Uh, Opioids, the picture is a little more complex. On the one hand, there was a higher risk of relapse because at least initially methadone and buprenorphine clinics closed down, though that seems to have started to bounce back a little bit. But we know that even the current opioid crisis has its roots in the great economic recession of 2008, 2009. And we don't yet know whether the current recession will lead to another worsening of opioid use disorder. We do think, though, that given that regulations have already been put in place, it might not be as bad. Nonetheless, these are all issues where we need more data. And finally, benzos. There's no definitive data thus far, but an increase is almost certainly to be expected. Uh, as geropsychiatry, we are in some ways the clinicians most sensitive to what benzos can do and the least prone to prescribing it. But in talking to my colleagues, I think we've all agreed that we are prescribing more benzos at this point than we used to. That's partly because anxiety is high, and at some point there is a need for more immediate relief, which benzos can provide. So our estimation was that if we are doing it, there's a decent chance that those in primary care, those in internal medicine, especially in deep community settings, may be finding themselves pressured in similar ways. I'll again be curious to hear what observations are in this group. Now, we do know benzo use tends to return to baseline following the resolution of an acute crisis, but this crisis has lasted for a year and there really is no precedent for something like this. So we'll see. I'm not going to spend too much time talking about nursing homes today, but given that we're talking about aging, I wanted to acknowledge that across studies, 35% of nursing homes had at least one COVID case. And now these are numbers from last fall. So the true number is probably higher at this moment in time. About 43% of nursing home patients that were infected needed hospitalization and 31% died. More recently, nursing homes have gained better control over the virus than the community at large. But I think we do need to see, and we will see, a large scale rethinking of nursing home regulation in the context of the pandemic, and that would be appropriately so. Among nursing homes, factors associated with higher probability of cases include a larger facility size, being located in more urban environments, greater percentage of African American residents, though that part's probably from just the fact that many of these early studies were from urban environments, And finally, non-chain status. So there are nursing home facility chains. And because those have some more protocols than regular nursing homes or non-affiliated nursing homes, there's a belief that they may have done a little better. But there's still a massive shortage of data on its impact on COVID recoveries, non-infected residents, excuse me, something popped up, and family members of nursing home residents. So very much a work in progress, finding about how this is all playing out. Let's pause for a moment though and talk about grief. So just to refresh on the basics, the terms grief and bereavement are sometimes used interchangeably, but there is a difference between them. Grief basically refers to the experience of, I don't know what happened here. Grief refers to the experience of losing a loved one. Oh, I'm sorry, bereavement refers to the experience of losing a loved one, and grief is the natural reaction to that bereavement. And there are steps. So we know about the 5 stages of grief, and I'm not going to dwell on those in great detail, but I want to talk instead about what we can do as clinicians to help someone move through the 5 stages of grief. So starting with denial, then anger, then depression, bargaining, and finally acceptance. That is the process of going through grief. But there is an acronym, and the acronym is HEALING. That was coined by the Complicated Grief Center at Columbia University. And it's a nice set of tips for clinicians, but also loved ones or people suffering from grief that sort of assist with the process of moving through the grief in an appropriate way. So the H in healing stands for honoring your loved one. E refers to easing emotional pain, and that often means acknowledging it. The A stands for accepting grief and letting it find a place in your life, so avoiding denial. L is learning to live with reminders of your loss. Again, to not avoid, but accept and recognize that the acceptance of that grief will integrating memories of your loved ones. That's the I. N is narrating stories of the death for yourself and others. And G is gathering people around you, including the community, and letting people in and letting them support you. So in general, it's a principle of acknowledging the grief, not avoiding it, embracing and cherishing rather than putting aside memories of the person you've lost, and leaning on others as applicable for help. What happens when someone is not able to go through the process of grief appropriately? It leads to a condition called prolonged grief disorder. This is not a formal DSM diagnosis. It's listed in the DSM as a term that is, or as an entity that is currently under study and consideration. What causes someone to not go through the process of grief appropriately? And there's an acronym for that as well. And the acronym is DERAILS. It often is seen in cases where death was sudden or traumatic, for example, suicides. And the things that people are left with that may impede the grief process. The D stands for doubting that you did enough for the person who died. Embracing ideas about the grief that make you change it or want to control it, which is if I don't accept it or if I do this instead, maybe something changes. Magical thinking, basically. Repeatedly imagining scenarios where the death did not happen. Anger and bitterness. Insistent belief that this death was unfair or wrong and shouldn't have happened. Lack of faith in the possibility that you can move on from this. Excessive avoidance of reminders of the loss. Rejecting support from others. And finally, survivor guilt. And if you think through all of these factors, I think you recognize that the COVID-19 pandemic is unique in that it may predispose people to prolonged grief disorder. We know that for most people, the circumstances of death do seem sudden and unexpected. We do know that a lot of people died alone and their loved ones could not be there at the end. And then there were restrictions on visiting policies. the context of the death matters too, that these tended to be sudden deaths. There may have been a sense of unfairness about the losses. And then the usual rituals that sort of follow a death in many cases could not be implemented. So, funerals or burials or other rituals. Uh, Compounded by the fact that there's now worries about employment or financial security, and then just safety if you've had a loved one with COVID dying around you. And then finally, the consequences of the death, of being alone, of contamination, of having others to care for. I talked about financial worries already. I did learn that in the Navajo community, a unique factor was that because some Navajo traditions say that one cannot continue to live in a house where someone has passed away, that in cases where there was a death in the house, among those that were most traditional, that there were fundamental issues of could they even continue living in the same house anymore. The staff at the medical center therefore dealt with too many cases where people were brought in when they were close to death, simply because the family did not want them passing away at home. So they ended up getting a lot of very end stage patients, and that was traumatic for the staff. I think we're only starting to unwrap some of these specific issues around COVID and grief. But my basic recommendation would be that if you have a patient or a loved one or a staff member that has experienced COVID-related loss, it starts with validating it, providing support, whether or not they're open to it, uh, but encouraging discussions about this, because if we were to find ourselves dealing with an epidemic of prolonged grief disorder, I think that would be catastrophic at multiple levels, to say nothing of overloading the mental health system. How can you manage prolonged grief disorder? Like I said, active empathic listening, help people understand and accept their grief. And this sometimes involves naming emotions, including anger, including bitterness and resentment, and then observing and reflecting on them. We know mindfulness and other emotion regulation strategies can work. Inviting bereaved people to talk about the story of the death. Sleep is important, but sedative medications should be avoided. And then one also needs to recognize that there can be symptoms like depression, anxiety, and trauma, even when there is no prolonged grief disorder. For those that are connected to the internet or proficient at using phones, there's any number of online groups and self-help interventions. And there are specific dedicated psychotherapies. Complicated grief therapy is the best studied one, available at Columbia University. And for those working among Indigenous communities, I think leveraging traditional approaches is actually essential. Let's also talk about the impact of isolation and loneliness. So in the big picture, there are disasters that bring people together, and there are disasters that pull communities apart. This one, it's interesting. On the face of it, it will pull communities apart because there's so much isolation and an inability to communicate. On the other hand, we're starting to see that, especially among older adults, a combination of using technology and the fact that communities have rallied around them has mitigated that. So it's not black and white. We know, for example, that things like the Kennedy assassination or the Challenger disaster, and in some places 9/11, brought communities together. And the way the impact on mental health was measured was what happened in suicide rates. And after the ones that bring people together, suicide rates went down. But in disasters that drove people apart, suicide rates have gone up. I think the story of COVID-19 is still being written, and it's often 5 to 10 years before the data can be reliably collected and interpreted. But we will be studying this very carefully. Also understanding that social isolation, social support, and emotional support are connected but distinct terms. So social isolation is a quantifiable entity that's measured based on the number of communications or the processes by which social ties play out. So for example, the number of phone calls, the number of visits, the number of text messages, if you will. And when these go down, that's social isolation, but that's different from social support. Social support does not refer to quantifiable actions. It refers to the functions that a relationship provides. So is there support for example, getting your food or grocery shopping or taking children to school or things like that? And the better the social support, the better the outcomes as far as mental health goes. But social support is different from emotional support. So emotional support is the psychological experience of either feeling or isolated or connected. And it's more a subjective thing. It's not an instrumental or quantifiable entity. So you could, for example, have no social isolation and excellent social support and still feel a lack of emotional support. And it works vice versa too. You could be socially isolated with minimal social support, but excellent emotional support. If there's a small number of dedicated people that cause connectedness. This is why in many assisted living facilities, people felt emotionally supported and connected, even though they were quite cut off from the outside world. Uh, we have been using some measures to quantify the isolation, partly because we believe that that's a big predictor of mental health at the moment. So just as standard, we like the UCLA loneliness scale, which is a quick 3-item measure, though more elaborate scales are available for those that are interested in doing this in a research setting. Now, I do want to sort of emphasize that the story of COVID-19, aging, and mental health is actually not doom and gloom, quite the opposite. So in August, the CDC released this report, and it was all over all the big media talking about how devastating the pandemic has been on mental health, especially among the younger population. When I read this report, though, the thing that really stood out to me as a geriatrician was this last line. Um, that's a massive difference in rates of mental health. So 6.2% in 65 and above compared to almost 50% for anxiety. Same for depression. Trauma-related stress was a little higher in older adults, but minimal or increased substance use, minimal new or increased suicidal ideation. Across the board, actually, it's a very tidy age effect. Now, and this is from summer, but just a week ago, the same group published follow-up using the same data set, data from the fall. All of these trends have held. So we know that at least through fall, older adults have done sort of strikingly better than every other age group in withstanding the effect of the pandemic. Now, in my editorial role for the American Journal of Geriatric Psychiatry, when I saw this, what was striking was that this finding actually was quite consistent with a couple of other papers that we had published. This was one that actually did a before and after comparison among 73 older adults that actually had major depression. And they looked to see if depression got worse after the pandemic, and they found that it did not. So there was some anxiety around fear of getting the illness. But 2 months after the pandemic, even those with pre-existing depressive symptoms did not get worse. And these were all older adults. This was a different study looking at post-traumatic stress disorder. And it was an ongoing study, and they did a similar before and after comparison. Here they found not only did people with prior PTSD do better, that actually the trauma-related stress seemed to go down. So they kind of proposed this tantalizing hypothesis that for those with PTSD, they may have some trauma inoculation that was actually actively protective to the impact of the pandemic. Now, these were short-term before and after data. It's not clear whether these findings hold a year into the pandemic, but we're looking forward to seeing those numbers. And it wasn't just the US either. Studies all around the world found exactly the same thing. 700 plus people in Hong Kong, 1,600 plus people in Spain, that those over 60 showed less distress. A smaller study in mainland China, and these are just 3 studies. There's papers reporting more or less exactly the same thing from Taiwan, from Singapore, from India, from the Netherlands, from Italy, from Brazil, from Canada, all over the world. We never see findings so striking. Um, Older adults have withstood the strains of the pandemic, at least through October, that we know of, better than younger groups. Why might this be? We think it's related to resilience. What is resilience? It's a multi-dimensional dynamic capacity. So it's not a monolithic, either you have it or you don't kind of trait. It's basically the end product of a number of different internal factors like cognitive capacity or personality or physical health, and external resources like social status or financial stability. And in the context of a given individual, in a given circumstance, the interaction of these determines whether they have better or worse outcomes. So any of us may have resilience in the context of one issue, but not in the context of others. In this case, though, it was clear. Now, can there be a biological factor? Yes, there can, and it's related to the biology of stress response. Overall, in the context of COVID-19, you can think of resilience as the net effect of a number of different variables that collectively seem to decrease the risk of worsening existing mental health conditions or developing new mental health conditions. And then some of this is hypothesis, but there is an entity described in older adults as oneliness, which is kind of the counter to loneliness. It's the ability to be alone but contented. It's there's not a lot of literature on it, but it has been shown to be commoner in older adults than younger. And then finally, wisdom, which is now also thought of as a biological entity, a complex personality trait comprised of empathy, compassion, emotional regulation, and self-reflection, plus the ability to accept diverse perspectives, better social decision making, and spirituality. In the context of indigenous elders, this has been talked about quite a bit, that they are culturally the guardians of ancient traditions and leaned on for their spiritual teachings, but also their wisdom. There's been some research showing what the determinants of resilience might be, just in intervention terms. We know higher physical activity and better social connectedness, and a better ability to adapt to telemedicine and digital communication. Uh, it's not clear which factors are the most weighted. It probably varies by individual, and definitely the presence of resources plays a role. And because this has been such a prolonged stressor, I think the story is still being written, and there may be some worsening of outcomes in the longer term. Uh, I also came across this article in Smithsonian Magazine, it's the March issue, uh, that talks about how Navajo physicians are battling the pandemic. And there was a couple of traditional concepts that I think are at the root of why the community seems to have emerged from COVID in relatively better shape. I won't try and pronounce this, and because I will butcher it, my Navajo pronunciation is not where it should be, but uh, Hojo, that may not be the right way to say it, is a philosophy of harmony, beauty, and mental and spiritual wellness. And it refers to a way of walking this earth that is inherently good. Also, Ke'e, which is the fundamental value of kinship. So, culturally, Navajo tradition is based on this idea that people should live in ways that are good, and inherent in that is the idea of being supportive and helpful, and that kinship is essential. So it's a culture that, even though the population is spread out, it's a culture that believes in togetherness. And then finally, I love this quote from Dr. Lawanda Jim at NNMC, and I had the privilege of meeting her, where she talked about how there are stories that tell of previous times when the indigenous people dealt with monsters and how they survived and overcame them. And I think this is a useful context to have at this moment in time, because it would tell people, it would reinforce that they are a culture for whom battling through stressors is inherent. In fact, it's fundamental. And it's a nice way of adapting cultural principles. For me as a geriatric psychiatrist, I also noticed that all across the Navajo reservation, there were signs like this, where they used the fact that they were all obligated to protect older adults as the reason why they should obey curfew, take standard precautions, and wear a mask. Uh, it's not clear whether this is somehow also why the vaccine uptake has been so high. And I'm actually curious to hear from the audience what their thoughts are on this. This is by no means my area of specialty. But eventually, this is an overall, this resilience is an early finding. We still don't know the impact of chronic stress and societal trauma. Uh, we recognize that the epidemiological data say that there's higher resilience, but we don't know how this translates at the level of the individual. Plus, we don't know what this means for special populations, whether these findings hold or not. So minorities, nursing home residents, dementia caregivers, etc. As I've said a couple of times already, the story is very much still being written. I'll run through this next part a little quickly so we can leave room for discussion. But COVID-19 is global in a way nothing else ever has been. For any of us, we will be able to have a discussion about the personal experience of COVID with anyone from anywhere in the world, with the exception of these 12 countries that have had no reported cases. 2 of them are closed nations, so we can't really count on the information we get. And the other 10 are islands in the Pacific that have a much easier time shutting themselves off than countries with open borders. But in the literature, there are so many, I thought, geographically specific reports in the literature that were just a reflection of how the processing of the pandemic has been global and multifactorial. In India, for example, there was a study reporting 5 suicides among older adults that were related to the lockdown rather than the pandemic. And India had some of the strictest lockdown measures early on. In Italy, we might have read about how doctors had to restrict ICU care early on based on age. So when there was a limitation, older adults were not allowed into the ICU. And it was a terrible experience for the providers that had to make those choices. In the Hispanic Caribbean, so the Dominican Republic, Puerto Rico, and Cuba, they actually did better in putting measures in place because the governments were already equipped to deal with epidemics, including Zika, dengue, and chikungunya. In the Philippines, they talked about the high prevalence of COVID in multi-generational households. And because the Catholic Church continued its functions until later in the process, so there were a lot of, and multi-generation households have been an issue in a lot of indigenous communities as well. In Australia, they talked about how the pandemic came on the heels of some of the most devastating wildfires the country had ever experienced, and it was sort of the double whammy. And then in Norway, which is by all accounts an affluent country with a small population, they struggled because in Norway, a high proportion of older adults live in nursing homes. And because they suffered so much loss there, it's led a new nationwide initiative to secure palliative care plans and end-of-life instructions, because in many people, this was not even in place. And this has been one of my favorite papers because it comes from North Africa and the Middle East, which is a region from which we don't hear about very much. And it was written by 10 psychiatrists that just compared policies put in place. And what they found is that almost every country had some measure for the care of older adults, but only Qatar and Egypt actually had government task forces focusing specifically on mental health care and aging. So there's been some nation by nation variance. And this doesn't even speak to the region by region variance in the United States, which we still don't have great data on. I want to very briefly talk about the work of our lab. And this is to make the point that the pandemic has spurred quite a bit of innovation as well. Our innovation is just using new cutting edge technologies, though innovation really applies even to improvised approaches to managing patient care. We've been working with a company called Emerald that was born out of MIT, and they have a radio sensor that can be used to detect movement without the person having to really do anything. So you see the volunteer walking on a spiral on the floor, and in the lower left-hand corner, he's the red dot. The gray arrow shows you where the device is located, and you can't see it because the device is on the other side of the wall. Think of it as a Wi-Fi router, which instead of providing internet access, can measure movement based on how these radio waves bounce off the body. Using this, we can collect data of this kind, that you can differentiate a high activity versus a low activity day. What happened for us is that we were using this technology to study people with dementia in their living environments. But when COVID hit, we found that actually having a tool that can monitor people's behaviors within their living area without requiring anyone to walk in or physically interact with them could prove quite useful. So we've repurposed it to facilitate remote interaction-free, contact-free monitoring of health. This device can also measure things like respiratory rate because it's sensitive enough to pick up chest wall movements. And using this is very early stage data, but we showed that for one of our patients, you could see that when he was acute, his average breathing rate was 23. And as he recovered, even 4 days later, you can see the average breathing rate goes down. It's really not possible to get data of this granularity without using advanced technologies like this. We haven't published these findings yet, but the Boston Globe heard of it. So it's been in the lay media before it's been in the scientific literature, which is the first time that's happened to me. So just to quickly summarize, the story of COVID-19 and mental health with aging has just begun. There's multiple mechanisms, both direct and indirect, by which the virus can impact mental health. Among older adults, behavior change is often the first symptom. Loneliness and isolation, and then more recently, disruption of routines are major stressors. Adapting to video technology to help communication may have been protective. There's global evidence of at least initial resilience to the mental health impact, but the longer term impact may be much worse, and we'll find out soon enough. Thank you.
Thank you so much, Dr. Vahia. That's an incredibly efficient presentation. There is so much in there, and I could easily take up another hour with questions that I have alone. Of course, we won't do that. First, I want to invite everyone to share any questions they might have in the chat feature. We're going to keep an eye on that, and the folks at ECHO are going to help me be aware of questions that might come in. But I have a series of questions for you. First, just in general, just as a reminder for everyone, because as we talked about before the call, there's a range of specialties and personnel represented. The general principles of grief and bereavement that you described early on, those are generalizable across cultures. Am I correct in just starting with that foundation?
Yes, yes.
Okay, and it couldn't be more timely that you've just come back from NNMC. Thank you for going out there and joining our colleagues. So with the understanding that we're talking about generalizable grief and bereavement experiences, can you talk a little bit about when, for the primary care folks and other folks who deal with the acute care matters and see patients on an acute care setting, we're hopeful that we're seeing a stabilization of the COVID pandemic right now. And I think, with the vaccine, that's all I'll say there. I think we're all quite hopeful about that now. So moving forward, as folks are managing patients in the outpatient setting, what kind of timeline does grief emerge on? For example, as we talked about before the call, it seems like there may be a trend towards, now the dust is settling with the acute, high volume, high morbidity, high mortality experience among healthcare workers, or rather that healthcare workers are experiencing among patients. What should we be looking for as we're managing healthcare workers who are patients and patients in general moving forward over 1 month, 6 months, 24 months? Where would we expect to see a spike at a specific point in time, or is this something that can come up at any point moving forward for folks?
So typical grief, it's a down. So we expect the worst of it to be immediately after the loss and then resolve over a period of time. It's somewhat arbitrary, but 6 months is kind of considered the time point by which grief should resolve. We expect some of that is not going to apply to the pandemic because for a number of reasons, I think people have not been able to follow the typical trajectory of recovery. In general, I think what's not clear, and I think this is something I picked up on while I was at uh, at NNMC, was that there were people that had experienced losses 7, 8, 9 months before, for whom that loss was still fresh, and it almost felt as though they had kind of buried it under the fact of needing to show up to, and I worked with staff, so it was a small slice, but needing to show up to work and do what needed to be done to support the community. So is it fair to say that that 6 month timeline should probably start now? Uh, Perhaps. I think what we want to make sure though is that it's being talked about with patients. If there is a patient that suffered the loss of a loved one, it should be discussed. Their emotions should be discussed and tracked. Uh, and simultaneously, I think monitoring other behaviors that are coming up, suicidal ideation, but also more substance use or alcohol use, things that they may not necessarily report unless you ask for them. I do think the use of a quick screening tool like the PHQ-9 can help, because it would, even if the data themselves are not as reliable, I think the act of having to go through it at every session, I think make sure that mental health at least remains a focus. And then if you find that the numbers, it's been now 3 months and over 3 months, the numbers have not changed, that's probably a pretty good sign that something's going on.
Thank you. Thank you for that. And Dr. Strominger had a follow-up question to that, and then we'll get to Paula Carter's question. Having just returned from Shiprock and working with healthcare workers in that setting, could you speak about your impression of what might be best practices for meeting the needs of healthcare workers and colleagues, specifically in the IHS space?
Sure. Uh, a simple one, and I cannot emphasize this enough, is to ask somebody how they're doing. Um, and I think the way you ask it matters. So there's different opinions on what the right way to ask is. My preferred approach has been not to ask how are you, but to ask are you okay? Because when you ask how are you, you give someone a reason to brush it off and say I'm doing all right or I'm doing fine. When you ask are you okay, I think that's a little more emotionally loaded question. It makes the assumption that you may not be okay. Before the pandemic, I mean, the correct social answer to how are you was how are you. So that's more a social greeting. I think are you uh, others may have preferences. I think this is not absolute, but that's what I asked. That's the approach I used while at Shiprock. And I was actually quite taken aback by the potency of the responses, in that it would be a perfectly friendly conversation and superficial conversation. And I would pause and I would ask someone, are you okay? And, you kind of get the initial surprise at being asked, then the deep breath, and then out it would come that, I'm not sure or I'm not okay. I gave a version of this talk at the Shiprock Medical Center. I don't know if anyone in the audience there is listening in, but when I first put up that slide about the statistics on Navajo Nation, I noticed that there were people in the audience that actually had a visible emotional reaction to that. And I asked them about it afterwards because I've never seen anything like it. And they said, even just seeing those numbers put up like that, and the fact that I knew several of those people, I think what's happened is that there's just a lot of emotion, fatigue, grief, anger under the surface. And I think it's important as clinicians to tap into it. The other thing I want to say, right, and I say this with great respect towards everyone in the audience, but we, myself included, are not immune from this. So this is not just applicable to patients or colleagues. I think it's important to acknowledge this for yourself as well. I will declare here that I had conversations with my colleagues to prepare for what I knew I would experience at Navajo. And while I was there, because my job was to meet person after person and group after group and basically uncover their pain, eventually, while it was fine to do, the sheer volume of it meant that I lined up some support for myself just to process things that I had heard. So there's many layers to it, and we don't have to be the ones bearing all of it. It anyone that's taking this on has to realize that this is going to impact them too. Because unlike the old days where you would help with someone with their grief, it was their grief and you were the clinician. The nature of the pandemic is such that everyone's experienced loss of some form or the other. So you can't, those borders are not as clean as they used to be.
Well, thank you for your candor and leading by example on that last note. I think that's critically important, and I hope everyone takes a moment to think about that advice and heeds it. One final follow-up question on this, and then we will go up to Paula Carter's question, is do you identify or can you comment on, we've got a lot of folks who work in our health facilities who are healthcare workers, and there's a lot of focus on the people who are the bedside clinicians, the providers, the nursing staff, but we got a lot of other folks who have been, who are exposed to a lot of trauma, who I think, unfortunately, sometimes are not thought of maybe as the frontline folks that they absolutely are. So you may see what I'm getting at. Can you comment on potential groups that you see as high risk that are not necessarily getting having this type of discussion, having this type of attention around their well-being?
Yes, I think actually anyone that works in the hospital that is not clinical should have the highest attention. Uh, Housekeeping, facilities, um, uh, nurses, aides. I know that there's been places where people were redeployed to other clinical areas that they were not familiar with. I think even clinicians, there were specialties that don't typically see death: optometry, dentistry, health education, and wellness that saw death. I think those that don't typically cross paths with death on a day-to-day basis and were exposed to it, I think are at a higher risk because there's a lack of a certain inoculation to death. Um, Everyone's important, and I actually think that there will be. I think this is true for every institution. It's IHS included, that we will start to see some of these undercurrents of resentment and internal sort of, that some people got the glory, but we all worked, and some people got the support, and we all didn't. I think for those that are in leadership positions, but even those that are not, in some ways, those that were not frontline but in the environment need greater attention at this point, because those that are at the front line, of course, they need help, but they're likelier to get it than those that were not. And I think that discrepancy needs to be acknowledged and addressed.
And on that note, it'd be interesting to know if the principles of the observations and the data you shared, which was absolutely fascinating about older adults having a bit more resilience to trauma, does that bear out for those frontline personnel who are exposed to death on a frequent basis? Having a bit more resilience, yet receiving the first attention because they're on the front line, whereas the folks who are not often exposed to death, as you described, having more vulnerability to trauma in this event.
Yeah, I mean, none of this is supported by data, right? So anything I'm saying is conjecture, and I reserve the right to be proven wrong on it. But I think they probably were more resilient. I think they're more used to dealing with it than others who were not. And I know at NNMC, for example, they had to rely on staff from departments like dentistry to actually help out and man ventilators. And we had a conversation around that it was a very different experience for those whose day job was not in the ICU versus whose day job it was. And I think similarly, that I think it's a pattern we will see repeated everywhere. I would say that housekeeping everywhere should probably get special attention, because they're often the ones that have to do the work of cleaning up after a death, or helping move a body or things like that. And I think they're everywhere. Their job in some ways is to not be seen or not be, it's to sort of work behind the scenes, and yet they see it all. And I think that actually leads to a much higher amount of emotional toll because they or anyone else whose job it is to sort of operate in the background and keep the ship running. Because when they do their job, no one notices. But when they don't do their job, it becomes immediately evident. So the positive reinforcement is not there, so the negative reinforcements might be. Um, I think this is so. I think this is true everywhere. It's not, like I said, specific to any institution. But I would urge us all to look at that.
Thank you. I appreciate those comments and couldn't agree with you more. I want to be respectful of your time. I know we're at the hour. Do you have time for two more questions that seem to be closely related? Yes. Thank you so much. The first is from Paula Carter, who asked, and I'll read her question. When speaking of Native peoples who survived other epidemics, might there be a genetic or at least a transmitted survival behavior that is a resilient factor now during COVID? And a related question from Michael Shields is, he says that he's interested in the data you shared. I think we all found that very fascinating about the resilience among older generations. And he wonders if there's a way that that resilience among older individuals in the population could help younger folks.
Excellent questions. There is evidence that some degree of resilience can be biologically transmitted. It has to do with stress response factors in the brain and receptor concentrations. We probably don't have time to get into the complexities of the biology, but we know that can impact gene expression, and it can actually impact neuroplasticity. There's reason to believe that the impact of trauma can be transmitted. There hasn't been a literature that I know of specifically looking at resilience, but I really see resilience and trauma as two sides of the same coin. So to the degree to which the impact of historical trauma can be transmitted, it stands to reason that historical resilience probably also has been transmitted. And does that then move from generation to generation? I think that's more a factor of the environment and the culture. I think in cultures where there is that sense that seniors have something to offer and teach and that we are obligated to learn from them, I think some of that cumulative wisdom often does get passed down. I think that's why based on the conversations I had, it's why the community of seniors, at least among the Navajo, was seen as a treasure that needed dedicated protecting, and that it was the responsibility of everybody to make sure that happened. This is not culturally necessarily true for everyone in the US. Yeah. But yes.
Well, Dr. Ihs Vahia, thank you so much for joining us both in person by working with our colleagues at Northern Navajo Medical Center and virtually this week on this session. We are very grateful for partnering with us as we move through this phase of the pandemic. And this has just been an incredibly rich discussion. I wish we had more time, but I want to be respectful of everyone's time who's joined us today. So thank you so much for sharing your experience.
Thank you, all of you, for all you do. It was a true honor to go to Shiprock, and it's a true honor to speak here today.
Thanks again. And thanks to IHS leadership for supporting these sessions every week, to the Project ECHO team for keeping us running smoothly all the time, and for every one of you who joined us and took time out of your busy schedule to take part in this session. Please join us in 2 weeks for our next discussion. And don't forget, if you have any interesting cases, please cut and paste the form that Dr. Strominger shared earlier. We'd really love to start some case-based discussion around folks' experience with COVID. So thanks again, everyone. Take care and stay safe.